Yeah, today's presentation or lecture would be on veneering teeth with porcelain. In other words, we can call it as porcelain laminates or porcelain veneers. As it shows on the screen, all human desires are in some way related to beauty. So, in enhancing beauty is one way where all dentists, especially the aesthetic dentists, are involved in. Myself, Dr. Sanath Shetty, I am a professor at the Department of Prosthodontics at Yenepoya Dental College, Yenepoya University, Mangalore. So, what are my goals for today? It is to inspire and to be inspired. Now, how and why are concepts changing today? How does failure occur? What are the available materials for us to deal with in the present scenario? What are the different preparation designs for laminates? What have we learned from the previous generation of materials and techniques with which we have now come to this advanced stage where we can make sure that things are always as precise and as effective as possible? And what are some of the variables that affect the outcomes of the treatment that we are going to provide for our patients? If you look at this picture, you will come to know that in the past when we did aesthetic work, we were slightly held back because whenever we looked at aesthetics, we always had issues with strength or function. But today's generation of materials have leapfrogged in such a way that we have materials which could provide us aesthetics and function at the same time. Means you can have strength as well as aesthetics at the same time. So that gives us a real longevity to most of the aesthetic restorations that we do. Now looking at it, why porcelain veneers? So now when I put this question, why porcelain veneers, I am actually looking at telling you why veneers instead of crowns. So there is always a general tendency for all clinicians to try and do a crown with the fear that a porcelain laminate would come off or it might fracture or fail. The reason why we are trying to propagate porcelain veneers is that preparing a tooth for a crown typically involves removing 63 to 76% of its tooth structure. And when I say that, we all have to understand that the three parts of the coronal part of our tooth structure involves a very hollow cavity in the form of pulp. So when we do a tooth preparation for a crown, we always think that there is enough tooth structure left, but what we need to understand is that beyond this dentine and inside this dentine, what we have is a hollow cavity which is occupied by the pulp, or sometimes, many a times, restoration in the form of post-endo restoration. So once we do a prep, we always are removing almost 75% of the tooth structure, and we are left with only a quarter of the tooth structure when we do a prep for a crown. But that's not the case when we prep for a veneer. We are most conservative of the veneers are almost 3% of the tooth is reduced, and the most aggressive form of preparation for porcelain veneers, we remove almost 30% of the tooth structure. So that's still half or less than half of the tooth structure that has been removed for crown prep. Now porcelain veneers also, the way they handle light is similar to natural tooth, giving the tooth a lifelike appearance. So why porcelain veneers is that there are other veneer materials available like the composites or no prep veneers, or there are so many other different materials which are available, but among all of them the most aesthetic and the most long lasting or most durable surface that we have is the porcelain laminate veneers. A porcelain veneer surface resists wear as well as staining, creating a very durable surface for us. Now looking at this picture, you might understand, or you can make out that these veneers are so thin, they are so translucent or transparent in some areas. So they are wafer thin, and but they can successfully withstand all the wear and tear that goes through in our mouth, that is ultimately it is exposed to over a period of time. How does that happen? So although porcelain is inherently brittle and easily fractured if dropped or flexed, when it's firmly bonded to a sturdy tooth structure, it's supported in a manner that it avoids these weaknesses. Now, forces directed to it are passed on to and withstood by the strong rigid tooth structure underneath. This is something similar to the furniture that we have, where a piece of wood is covered with a laminate, a thin sheet of laminate. So as long as the wood is strong, the stuck laminate on top of the furniture will always stay surface durable. So once the underlying structure, that's the wood, starts to fail, then the laminate also starts to fail. So this is how the porcelain laminate also works in the mouth. As long as the strength of the tooth is good enough, the laminate is a very durable surface, and the important thing is this laminate has to be very well bonded to the underlying strong firm tooth structure. Now, how do you classify porcelain veneers? So what are the types of porcelain veneers we talk about? So basically there are many types of classifications, but what interests me and what most of us should know is the type of the classification which is based on the indications for porcelain laminate veneers. Type 1 is the whitening resistant teeth. That means if you want to do laminate veneers for a patient who has discolored teeth, and you have attempted whitening procedure and it is still not changing in color, then of course we need to do a porcelain laminate veneer, because we are left with no other choice. That's a type 1 type. And the type 2 is the important morphological changes. So what are these morphological changes? The shape of the tooth which the patient is unhappy. The patient is not happy with the shape of the tooth and wants to get it changed. So that's morphological changes, like a peg lateral. The patient is unhappy with it, or maybe a spacing in the tooth, or a mild change in the chip in the incisal edges. So these are the morphological changes which the patient would desire to be changed. So those are type 2 type of porcelain veneers. And then the type 3, the mild malpositions of the tooth or teeth. Now this is many a times malpositions are most of the times corrected by orthodontic procedures, but there would be a situation where the patients would want this kind of procedures to be done on their tooth because they do not have enough time to undergo an orthodontic treatment, because they are close to some function, they are close to some important events in their life like their marriage. So they come to you and they want an immediate resurrection of the malpositions of the teeth, and when it is a mild malposition, many a times it could be managed with porcelain veneers. So when should we not do porcelain veneers? In the sense, what are the contraindications for doing a porcelain veneers? Most important thing is lack of adequate marginal or the internal enamel. Now why we are talking about this is, without enamel the bonding is not the strongest. So the bonding is the best when there is enamel, and as I told you in the a few minutes back, the longevity of these restorations are all because of how well it is bonded. If you don't bond it well, then the longevity is always questionable. Unrealistic patient expectations, of course, and unresolved functional issues, that's very, very critical. If there are patients having some functional issues like extreme wear or bruxism or night grinding or anything, traumatic bite, any of these unresolved functional issues, you give a porcelain laminate veneers in the anteriors, then these are bound to fail, because they're going to take that extra functional load which it may not be able to sustain, and they might fail or fracture. And of course, when orthodontics or bleaching is the right choice, so you need to make sure that these are the choices that are given to the patient first. And when considering that these are the more conservative type of choices, we should always make sure that these choices are acceptable to the patient. Now, who are the ideal patients for porcelain veneers? An optimal static and dynamic occlusal relationship is of prime importance in patients receiving veneers. So having a proper bite with a right kind of overjet, right kind of overbite, a good mutually protected occlusion or a canine protected occlusion. So when all these things are in place, they are ideal patients for veneers. Now, since the usual mode of failure is the fracture at the incisal edges, the incisal tips should be placed in such a manner that they do not contact the opposing dentition. So if there is a patient is having a traumatic bite like this, an edge-to-edge bite where the patient is already breaking the incisal edges of the natural teeth, then there is no chance for your porcelain veneers to be successful unless you make sure that this type of bite is taken care of. Of course, a healthy periodontium forms a sound foundation on which the restoration should rest. All restoration should rest on a healthy foundation. But in the form of veneers, when we talk about veneers, it is very, very critical that the periodontium is healthy, because when we are going to bond these veneers, it is very, very critical that there is no weeping from the periodontium. If there is a weeping, or if there is any fluid exudate from the periodontium, then definitely that's going to hamper your bonding, and when the bonding fails, the entire process or entire treatment fails. And of course, mouth breathers are considered as poor candidates due to their persistent gingivitis. And of course, when there is gingivitis, there is always some kind of oozing from the gingiva, and this again affects the bonding. Now we'll just look at these 4 cases, and we'll decide whether we can do veneers for these cases. The first one, as you can see in that picture, there is a malformation or malposition of the teeth, and patient wants you to do veneers and correct it. And is it the right choice? No, the malpositions is a little too much, so the right choice of treatment is orthodontics. When you can see in the second picture, patient comes for veneers and asks for veneers, then you look at the patient's teeth, and then you need to understand that this is not ideal candidate for veneers, because you need to understand that patient has already worn out most of his lower incisors and chipped off many of his upper incisors. So we need to first look into the functional issues and understand the biomechanics behind all these problems in the mouth, correct them, and then maybe look at doing veneers. Now when you look at the third picture, looks like ideal case for veneers? No, because the cervical region where the bonding is very critical, you can see that there is no enamel there, and lot of dentin is exposed, and this could again create a problem in the bonding, and when bonding fails, the laminates fail. And when you look at the last tooth, what does the patient desire? Patient desires a change in the shade of the tooth. Patient wants a lighter colored tooth, or a more tooth with more value. Then the choice here is bleaching, definitely not laminates, because every other aspect of this smile looks fine, should not be doing laminates. So we should be looking at bleaching and improving the color of the teeth. Now what are the important guidelines when you talk about preparation for veneers? So most conservative of the veneer preparation is 0.3 millimeters. So we need to, of course we have heard of no prep veneers, we are not discussing that now. So there the most conservative of any veneer preparation is around 0.3 millimeters. The thinnest shell of porcelain that could be backed by a tooth structure is 0.3 millimeters. Now what you need to understand is that a minimum of 0.2 millimeters of additional preparation is required for each vita shade change. Now most of the times the change in color of the tooth, to whiten the tooth, we end up doing veneers along with other morphological changes, or any other malpositions of the tooth. So when we want to change the color, when we need to understand that the lightening the color, every vita shade change, that what we mean by vita shade change is from A3 to A2, or A3 to A2 to A1. So this one change in the shade, we need to increase the tooth prep depth by 0.2 millimeters. So this picture is going to give you a better idea as to what I am trying to tell. The first line that you see there, A4, is the shade of the patient, and the patient desires an A1 shade. So in that case, 0.3 to 0.2, 0.2, 0.2, if you go on adding, it becomes 0.9 millimeters. So a total of 0.9 millimeters of tooth prep is required for you to change the shade from A4 to A1. At the same time, if you want to move the shade from A2 to A1, you need to do a preparation depth of 0.5 millimeters. And you are doing a prep not to change the shade, only to change the morphology of the tooth or slight malposition corrections of the tooth, and you're not changing the shade of the tooth, then the preparation is 0.3 millimeters, because A1 will remain A1. And of course, at the incisor ledge or in the proximal area, where when we are closing the diastemas, a maximum of 1.5 millimeters of unsupported porcelain. More than that, of course, you are going to understand that there is no backing of the tooth, and unsupported porcelain can always fracture. If you ask me as a clinician, I wouldn't want to go beyond 1 mm of unsupported porcelain. Now this picture is very commonly seen because this is on the SPA factor, a classic chart by Lombardi. And this, with this we need to understand that when we finally desire the final restorations, we need to tell the technician as to what is expected from them, because when the technicians receive a model and they are supposed to fabricate the laminates, they have no clue about the other aspects. So we need to understand whether the patient is young, patient is old, patient is well built, masculine, female, male. All these things are very critical, and the shape of the tooth according to all these SPA factors needs to be considered before the final shape of the laminate is decided upon. So when a young patient is coming, we need to execute these slight morphological changes in the tooth to provide some mamelons. And of course, when a female patient is around for us, we need to have more curved incisal edges, and of course even the facial surface can be more curved rather than a flat facial surface in case of a masculine young gentleman. Now, golden proportions also make a big difference. Of course, in most of the times, or in every time, we would not be able to consider this and execute this. When does this come into the picture? This proportion comes into the picture when we are trying to close multiple diastemas. So it's not just that we can go ahead and close all the diastemas and make sure that the tooth will look fine in the oral cavity. We need to understand that the proportion between each tooth is very critical. The golden proportion says that if we consider the width of lateral incisors as 1, then the central incisor should be 0.618 size bigger than the lateral incisor when you look from the front. And of course, the canine should be just 0.618. Lesser than the lateral incisor. So I'm not telling that the canine would be less wider tooth than the lateral. What I'm trying to say is when you look from the front, the amount of surface of visibility from the canine is going to be only 0.618, and the rest of the canine's distal surface would be obscured from the vision from the front. So this we need to keep in mind when you are going to increase the size of the tooth when we are considering closure of diastema, and make sure that we are somewhere close to this golden proportion, otherwise aesthetics could be affected. Then of course the smile line is very critical. Now whenever we do any restorative work in the form of crowns or bridges, fixed partial dentures, laminates, or inlays, onlays, anything, the placement of the margin is very critical for us, and we do not want to encroach upon the space where the gingiva is there. So we have 3 different types of margins, that is the supragingival margins, the equigingival margins, and the subgingival margins. When you look at the first picture there, the patient has a real gummy smile, and the entire gingival architecture is exposed when the patient smiles. So when this happens, you need to make sure that the margins of your restoration, your porcelain laminate, is hidden under the free gingival margin. So you need to go subgingival to make sure that the margins are not exposed. So whereas when we look at the second picture, we can call it a tooth papilla smile, where only interdental papilla is visible and not much of the gingival architecture in the cervical region is visible. So in this case, we could try and execute restorations which could be equigingival. Whereas when you look at the last picture, however the patient smiles, we need to understand that there is no exposure of the gingiva, and these are the best patients for us, because we don't need to go and hide our margins under anything. We can be supragingival too, and unless the patient tries to lift the lip and show somebody that, oh, look at my new laminates, how does it look? Unless he does that, nobody is able to make out where the laminate ends and where the tooth is begins. So we can be supragingival in this case. So that would be the easiest patient to handle. And of course, when the gingival architecture is exposed in the form of a gummy smile, as you saw in the first picture in the previous slide, then all these things are also very critical. The gingival zenith. So the zenith of the gingiva, as you can see in this picture, it is not in the center of the tooth. The zenith is always slightly off center, and that is slightly distal to the center. As you can see in the central incisor, it is slightly distal, and this distalized position of the crest goes on increasing from the central incisor to the canine. So that means the central, the crest is little away from the midline, lateral it is little more away from the midline, and the maximum movement away from the midline is seen in the canines. So when the gingiva is going to be exposed in a patient during a smile, these things also need to be considered, and when it is not fine or you're not happy with it, we can bring in a periodontist to help us restore this gingival zenith. And nowadays we don't need to use the blade, we can even use laser to do gingivectomy and then correct the gingival zenith, as you can see we have done in this case. And of course, with the CAD/CAM designing and the availability of model scanners, and of course intraoral scanners are also available, where we can take digital scans of the existing arch and then plan the laminates on the computer, and then you can always show the outcome to the patient, or also we can use these scans and modifications or designs that are done on the computer to do the temporaries and show the patient how it looks, how much the size has increased and all that. And also you can see in this, the gingival zenith is slightly not in the same order. The 1-2 lateral incisor, the gingival zenith is so much lower in comparison to the 2-2, and also the canines are also not at the same zenith. So also we can tell the patient that, okay, when we want to close the diastema, what would be the eventual increase in the size by 0.3 millimeters in this case. So patient would be aware that how much the size of the tooth increases. Now, as you can see, in this patient we have executed both gingivectomy to improve the zenith, and of course we've done laminates to close the diastema, and you can see the outcome of the restorations. Now, when you have to do a shade selection, now what is the time? Select the shade of the restoration before you do the prep. That's very important. You can't do the entire procedure and then finally try and select the shade. So you need to select the shade of the adjacent tooth if you are doing 1 or 2 laminates in the anterior segment. If we are doing all 6 anteriors or all premolar to premolar laminates, then the shade of the adjacent tooth doesn't matter, because you would be having the entire anterior segment in the same shade. Now, the most widely accepted shade guide for all clinicians across the globe is this Vitapan classical shade guide. So this is very commonly used, and the language that this projects to the technician is well understood. And this shade guide, how do you use this shade guide? Okay, now this shade guide is based on hue chroma value, and we all know what hue is. Hue is simply the color tone. As you can see in the picture, it could be red, blue or yellow. Now in the Vita shade guide, how is it depicted? In the Vita shade guide, when we talk about A shade, it is reddish brown, that's the hue of A, and B is reddish yellow, and C are the gray shades, and D is the reddish gray shades. So first we need to select the hue whenever we try to do a shade selection. Now, what is chroma? Chroma is the intensity or the saturation of the same color, where from light blue to dark blue. Now in the Vita shade guide, what is chroma? Chroma is A1 is the lightest of the chroma, and A4 is the darkest. So from in the A shade only, how much reddish brown goes on increasing. The amount of reddish brown in the tooth, how much it is, that's the hue. How much hue it is, that tells us the chroma. Then what is value? Value is the brightness or the lightness of the tooth, how much white the tooth is. Some patients would come and ask, doctor, you give me the whitest tooth. Now how do we get the whitest tooth? If you arrange the Vita shade guide like this, you can understand this is arranged according to the value. B1 is the whitest tooth or the lightest tooth, and C4 is the darkest, and the highest value is for C4. And of course, translucency is a very important factor for us when we are doing work in the anterior segment. Now, what are the do's and don'ts for shade selection? Now, tooth color has an intimate relation with the color of the eyes, we all are aware, and of course the skin, as both these elements have the same embryonic origin and should be considered in selecting the shade. Instead of precisely matching the shade, a shade of the lower chroma and higher value can be selected. I repeat, instead of precisely matching the shade, a shade of the lower chroma and higher value can be selected. Why? Is because if you go wrong in the shade, it is easier to make the shade darker rather than to make the shade lighter. It is almost impossible to make the shade lighter, then you have to redo the entire restoration. Whereas in case you have a restoration where you think that okay, it is a little more lighter in color, you want it to be more darker, that's more easier rather than trying to make it lighter when you already have a darker crown or a laminate. This provides the dentist some leeway and allows for slight darkening attributable to increased translucency with polymerization of composite luting cement. Shade selection should always be done at the beginning of the appointment to avoid vision fatigue. Now, what are the clinical tips for veneer shade selection? Establish a properly lighted environment for shade selection. Select the final shade of the veneers based upon the patient's preference as well as the skin tone. So, there are many times the patients would always want the whitest of the tooth, but it is for you to suggest what would be the ideal shade for that particular skin tone. If the patient accepts, it is well and good. If the patient still insists that I still want the whitest tooth, then of course you need to listen to the patient and go ahead and fabricate laminates according to the patient's needs. Now, how do we start going about matching the shade? Hold the Vita shade guide and stare at the gray case for 20 seconds. Usually what I do is I just read VITAPANCLASSICAL. So, I read what is written on the shade tab case, and that gray would always neutralize the color in my eyes, and that would help me to select the hue better. So, first you select the hue of the tooth, and the best tooth to select the hue, or where the tooth which has got the maximum hue, is the canine. We all are aware canine could be the darkest tooth in the entire oral cavity. Basically that is because it has got the maximum hue, and that is easiest to select the hue of the tooth. And then of course we have to select the chroma, whether it's A1, A2, A3, A4, whatever. So, once you select that the shade is A, then you have to go ahead and select whether it's A1, A2, A3 and A4. So, take a photograph of the selected shade tab adjacent to the unprepared tooth. As you can see, in this case we are trying to do laminates on the two central incisors and we are not doing laminates in the entire anterior segment. So, selecting the shade of the neighboring tooth is very critical, so that we can match our laminates to that tooth. So, in this case the lateral incisor is showing A3 shade, and so we take a picture like that. Select the original shade of the hydrated unprepared tooth as a reference point. So, we need to know what is the shade of the unprepared tooth. It's a slightly darkened tooth, as you can see. The shade is more closer to A3.5. So, you can take a picture like that and select the stump shade of after the final tooth preparation and take a photograph. That is very, very critical. Many times once we reduce the tooth by 0.3, 0.5 or 0.7 millimeters, we would understand that the shade of the tooth changes. And which is the best shade guide? It is the Ivoclar shade guide, which will provide us the stump shade. This is nowhere near the Vita classical shade tab. This is completely different. The nomenclature is also different, and this is how you select the shade, stump shade. Stump shade is very critical for us to tell the technicians in our note, so that the technician knows how much dark the tooth is and then how much opaque the laminate should be. Because if after the preparation, if the tooth stump is very dark and the laminate is very translucent or even sometimes transparent, then the shade of the tooth underneath the stump shade would show through and you will not be able to execute the right color that you want. Now, this is a case that I am actually talking about. It is a case where the stump shade is very, very dark, and if you want to give the patient a very translucent laminate, then it is not going to work. So, these pictures are going to help the technician to understand that he has to use very opaque laminates. As you can see in the picture to the right, that those laminates are very opaque, and because they are so opaque, that's the reason the color from inside the tooth is not showing through outside. Now, what are the different materials that are available for veneers? And here I am going to discuss only the materials related to porcelain, not the other materials that we do have for making veneers. So, glass ceramics or the feldspathic porcelain is the most aesthetic among all the materials. This type of porcelain has been available for ages as of now, and but the thing about feldspathic porcelain, they are very aesthetic, very glassy, but at the same time it is very fragile. The strength is only 70 megapascals, and that is one deterrent when we want to use feldspathic porcelain. But if you are very sure of what you are doing, and if you have no functional issues and you want the most aesthetic of the materials, you need to go for feldspathic porcelain. Now, the other form of ceramics that we have, they are the infiltrated ceramics, the lithium disilicate or the leucite reinforced. So, these two ceramics do have some kind of infiltrations, and these infiltrations have increased the strength of feldspathic porcelain from 70 megapascals to 400 megapascals, and these are some of the examples. So, they are 50% glassy, so they do give a good aesthetics, and they are translucent and of course aesthetics, but they are not as aesthetic as feldspathic porcelain. Now, high translucent zirconia is also available now. They are very strong, 80 megapascals of strength that it provides, but no glossy phase. So, bonding is a little tricky issue when it comes to, when there is no glass, then bonding becomes a tricky issue. So, it is the least translucent, and of course it is aesthetic, but not as aesthetic as the two other materials that we discussed already. Now, two major principles governing the tooth preparation. So, we need to understand that the most of the preparations that we are going to do for laminates is going to be very conservative. Retention is solely by adhesion rather than by tooth preparation design. When we talk about preparations for crowns, we do preparations in such a way that we provide retention form, resistance form to our tooth preparations, so that the crowns are retained and they don't frequently debond. Whereas that's not the case with laminates. We are not dependent on the retention or resistance form. We are solely dependent on how well the laminates are bonded to the tooth. So, the preparation design doesn't matter. Now, what are the different types of preparations that are available when it comes to laminate preparations? So, again, they are classified into type 1, type 2 and type 3. Type 1 is the contact lens or the window preparations, in which the preparation does not cover the incisal edges, the facial only type of preparations. Okay, this is a type of preparation where you are not going to alter the length of the tooth, you are not going to alter the incisal edges of the tooth, everything remains the same. So, only the surface of the tooth is going to be changed. In such a scenario, you go for type 1 type of preparations, and where we prepare only the labial surface. Then there is the type 2 type of preparation where we want to alter the incisal edges. So, you slightly reduce the incisal edges apart from the labial surface of the tooth. So, this is called incisal butt or the conventional, and this is one of the most commonly used preparation design as far as laminates are concerned. That is a type 2 or the incisal butt type of preparation. Then there is the type 3 type of preparation, where apart from the labial surface, we even prepare the incisal edges and a portion of the lingual surface. Many clinicians even call these type of preparations as mini crowns, because we are going to even wrap the lingual side also. So, this is not a very common design of preparations, but when required, we do prepare the tooth like this, and this type of preparation would provide little more resistance and retention form, because you are going to wrap the laminate onto the lingual or the palatal side of the tooth. So, as far as path of insertion is concerned, the least restricted path of insertion is for the type 1 or the facial only type of preparations, and it is more easier to seat the second type, that is the incisal butt type of preparation, where when you place the laminate, you have a definitive stop on the incisal edge where it goes and sits. Whereas when you do a lingual wrap or the type 3 type of preparation with the extension to the lingual side, it is very critical that there are no undercuts. If there are undercuts, and when you try to seat these laminates, laminates being very fragile, they're going to fracture. So little bit of extra skills are required if you want to execute a type 3 type of preparation, laminate preparation. Now, what are the armamentarium that are required? I'm only talking about going to be the basic armamentarium. The most important part in our equipment that we need is the diamond depth cutter with a wheel diameter of 1 millimeter to provide a 0.5 millimeter prep, and depth cutter with a wheel diameter of 0.6 to provide a 0.3. That would be the most conservative among all the preparations. Of course, a round burr we need, and a round ended tapering burr to provide the very shallow chamfer type of margins all around. And of course, the finishing diamonds are required because we need to finish all around after the laminates are prepared using the regular diamonds. Many times we do make a putty index like this so that we don't go wrong with the preparation, and many times when we have to do the full anterior segment, these preparation designs, these prep guides would help us to execute our preparations better. Now, how do you do the facial reduction? Since the amount of enamel decreases at the cement to enamel junction, some teeth permit less reduction at the gingival finish line to a standard of 0.3 millimeters, and the reduction at the incisal half and incisal edge to a standard of 0.5 millimeters. We all know the quantum of enamel goes on reducing from the middle third to the cervical third. So when it is too thin in the cervical third, a regular prep of 0.5 millimeters may not be feasible there. So we may have to reduce the quantum of preparation in the cervical region. So these are the depth cut burrs that I'm talking about. These depth cut burrs would not allow you to prepare more than those rings that are seen in this. So these rings would provide, they're coming in different dimensions. So from 0.3 to 0.5, 0.7, 0.9 is also there. So but they will provide you only that much of reduction and not more. So this is how we go about doing this, a two-plane reduction. You can use this kind of burrs to reduce the amount of preparation in the cervical third. The second and the third diagram shows that these kind of shaped diamonds would provide little lesser reduction in the cervical third. Some clinicians would want to use a single cutting edge type of diamond. They can use this diamond to run through the labial surface like this. So these are also depth cut burrs, but they don't have 3 depth cuts, they have only 1 depth cuts. Now, facial veneer preparation is the most conservative among all the preparations. This is how we execute them on a phantom head, just for you to show. The depth cut burr is used, and this is in a clinical scenario where the central incisor is prepared. The cervical third, two-plane reduction, and once the depth cut is done, this is executed, then you use a round-ended taper to reduce the elevated portion of the tooth surface. So if you do not want to go beyond this elevated depth cuts, you can always create marks using pencil or some kind of pen, felt pen, to mark the depth of the depth cuts so that when you prepare, you don't over prepare. These kind of guides also help us to assess how much preparation is done. Now, when we do a facial only type of preparation, how exactly we are going to end our proximal preparation is very critical, because if you do not hide the proximal preparations, then it becomes an aesthetic problem. Now, you can see here in this preparation, we have taken the proximals almost towards the middle of the contact area so that these margins are hidden. These margins, you can see they are hidden. Whereas in this case, where we had to redo the laminate because the proximal margins were not hidden, it was too far facial. So we had to remove these laminates and then redo it. So carry the finish line again distally like this, and then execute the new laminates. Now, the incisal bud preparation, this involves the facial surface exactly like what we did for type 1, but at the same time we have to reduce the incisal edge. I would always prefer a max of 1 millimeter, but there are some clinicians who would say up to 1.5 millimeters is fine. So this is how we do this, reduce the preparation. We can place depth cuts on the incisal edge of 1 millimeter and then reduce the incisal edge like this, round off the incisal edges, and the finally executed incisal bud preparation on the phantom head. And then the lingual wrap type of tooth preparation. This is the, as I told you already, that's the most difficult among the preparations, because we need to be very careful in this scenario to make sure that there are no undercuts. So the path of insertion becomes critical. If there are undercuts, these laminates are not going to seat, and if you force it, they're going to fracture. Now, why do we want to prefer this kind of a preparation? The existing restorations around the incisal edge, there is a composite restoration which is around the incisal edge, or there is a fracture of the tooth which is extending onto the lingual surface. So we have to make sure that that fracture is covered in your tooth preparation. In such a scenario, we need to take the preparation to the lingual side and give a type 3 type of preparation. Where or defects on the lingual side, multiple diastemas are there, less than ideal enamel remaining, and you need to have some kind of retention and resistance form, because you can't solely depend on the bonding. In such a scenario, maybe you need to do a lingual wrap, and of course if you're changing somebody's veneers which is already lingually wrapped. The lingual reduction can be done using a lingual finish line is created by the round end taper burr by holding the burr parallel to the lingual surface and forming a slight chamfer of 0.5 millimeters. The lingual finish line depends on the thickness of the teeth and the patient's occlusion, of course. So this is executed on the phantom head. You can see the lingual finish line. There is absolutely no undercuts. The laminate would nicely slide in and sit onto the lingual finish line, and of course the facial finish lines. So the same type of preparation executed on this canine. Preparation is done. As you can see in the second picture how the lingual finish line is there for the laminate. And what are the rationale for tooth preparation? To achieve a sufficient and even space for the future restoration in case of morphological changes and malpositions of the teeth. So here we're only talking about morphologic changes and malpositions of the teeth. So when this is there, you need to do a wax up of the final shape of the restoration, and then look into the targeted restorative space. Now, what is the targeted restorative space? Whenever you are talking about changing the contours of the tooth, or when you are changing, correcting the malpositions, we need to understand that we don't need to prepare the tooth all around by 0.5 or 0.3 or 0.7 millimeters, because we are going to change the shape of the tooth. In some areas we need not even reduce the tooth, and in some areas we may have to reduce a little bit more. So that is the targeted restorative space. So we'll run through a case like this, where this is an anesthetic smile and a reverse smile line. Patient wants veneers for this. So what do? This is in the mouth. So we do a mock-up and then a putty index, and then we have a temporaries in the patient's mouth. So this would be the final, how the final laminates would look like, but these are just temporaries. Then the patient is sent home, patient is happy. Maybe a day or two, patient's temporaries are staying in the patient's mouth. If we are happy with everything, then we start prepping the tooth through these temporaries. So this would provide us the targeted restorative space, so that we are reducing how much we want to. So your depth cuts are placed through the temporaries, so that the actual tooth is not over prepared according to the final restoration. So you can see here in this case, and we have achieved the targeted restorative space, as you can see in that putty index, and this is the final outcome for this patient. To conclude this session on a brief introduction on porcelain laminates, and of course the different types of preparations, the indications, contraindications. So I would like to conclude by saying that tissue preparation is very critical, because bonding depends mainly on the tissue preparation. We don't want the tissues to weep during the bonding process of the laminates. If the tissues weep, then bonding is going to fail. Diagnostic models are very, very important. Diagnostic wax up and how the laminates are going to look. All these things need to be discussed prior with the patient, so that the patients are not at the end of the treatment, patients are not surprised with the outcome. And appropriate preparation guide to quantify the amount of preparation accurately is very important. Minimalistic approach to make the treatment feasible, predictable and repeatable. Supragingival, equigingival margins, the most preferred types of margins. 0.3 to 0.5 mm chamfer margins would be the most conservative among all preparations. Immediate dent in sealing to reduce post-operative complications like sensitivity is very critical. Every journey begins with the first step, and we need to take that first step if we want to do it. An objective without a plan is always just a dream. Happy patients is what we work for. Thank you.